So we'll start with Dr. Thirumalesh. There's a small change in the orders just to accommodate a few people who are having overlapping sessions. So he's going to speak on mitochondria, new biological findings in treating retinal diseases. There's going to be a mix of many specialities overlapping here, the dry eye, ocular surface, wound healing. So the whole thing has to be interactive. There are also a lot of people from the industry, people representing companies here. So if you have anything which is linking to your area of interest, you can just, there are mics there, or you can come forward and just ask a question. So there are scientists here who will probably help you to give some answers to this. So we'll start off with Dr. Thirumalesh. Ready?
Yes, sir.
Yes.
Thank you very much, sir, for this opportunity. And my topic is new biological findings in treating retinal diseases. Although the findings are not new, only thing is the way we are looking at the disease is a little new. This is the team that Dr. Rohit had put together and given us a task of looking at DR and AMD in new light. And when clinicians look at DR AMD, this is what we see. We know that there are drusen's and there are underlying RP changes that are there, and they are the reason why the disease kind of progresses when the RP gets stressed with age and with the inflammation. So there is cellular level of inflammation which is going on, and that's the reason. Now, what proof do I have to show is this particular slide. Now, you can see on the right side where those small orange things that are moving, these are activated NK cells, and you see that the NK cells are just moving over the RPE without producing any problem. Now, towards the right of your screen, you see that the RP cells, which got a little stressed, the contact with the NK cells induces what is called as pyroptosis. So in pyroptosis, what the same NK cell which was moving over the RPE without producing any problem kind of eats it up, right? So we are continuously collaborating with our collaborators outside to kind of look into newer treatment possibilities for dry AMD. And this particular collaboration had yielded a few interesting findings. Dr. Stina was working with Professor Ziegler, and they were working on crystallins. As we all know, crystallins are proteins that are present in the lens. But the same crystallins, when they are altered, with age, the protein expression gets wrong and the RPE kind of produces dry AMD, and this is one of the pathways which is now being pursued. This is popularly the mTOR pathway, in other words, and the gene responsible for the mTOR pathway downregulation is crystallin. Now, we all know that AMD does not have an animal model. That is because the genes that have been associated with AMD, if you downregulate them, it either kind of looks into the vitamin D pathway or how lipid is metabolized, because they thought that drusen has lipid in it. But when we kind of knocked out the CRYBA1 gene, we were able to successfully produce AMD in the mice, and you can see that as the knockout continued over 4, 6, and 12 months, we were absolutely able to produce the drusen's. So this is the initial proof that if you downregulate beta crystallin, the disease can produce an active working model of AMD. So we are pursuing this particular path of alteration of beta crystallin. Now, what we did was the next step where we were pretty much sure that when you alter the crystallin gene, it is going to work in case of dry AMD. So we took it forward and we did the first non-human primate study in the rhesus monkey. So first thing that you have to prove with any therapy is that it is not going to produce harm. So for that, we injected the CRYBA1 gene and also the AAV vector that we have produced within India indigenously, and in our collaboration, we are using the gene sequencing from the US. And what happened was we were able to show that there is absolutely no inflammation in the monkeys after the injection, and you can see both the OCT and the fundus pictures. We also did a fluorescein. You can see that they are as clear as, after the injection, it did not produce any kind of vasculitis kind of a reaction. So this is sequential imaging for up to 6 weeks. And once the imaging was done, we were supposed to produce histological proof. So we did the sacrificing of the animals, and we wanted to see what we have put within the eye, does it get integrated or not? You can see the green line on the bottom where I put an arrow mark already. So we were definitely sure that the RP picked up this particular thing, and it also was able to produce the protein that we put inside. Now the second part is we did not use the subretinal route because subretinal surgery is something which is very, very complicated and only a few can do. What we did here is we injected in the suprachoroidal space. So suprachoroidal space is kind of an office procedure. It's just like an intravitreal injection. And with that, we were able to produce gene within the eye and produce the protein expression that we wanted. Now we further studied if we put the particular thing in a live cell, does it work or not? Now this is a live cell image. You can see that the RPE cells, we put a transfection, we put the vector and delivered a particular gene fluorescent protein. Now, how it integrates with our particular gene, you can see that it initially starts in the nucleus, the GFP is there, and once the protein comes into the cytoplasm, you can also see that the particular protein is produced. So the vector works, the method works. If we are probably right, then very soon AMD, dry AMD can have treatment which can be used for the betterment of these patients. Now, the other disease that we are closely looking at is diabetic retinopathy. This is a single slide where it has summarized how diabetic retinopathy initially starts as metabolic dysregulation, then goes into subclinical or cellular, intracellular inflammation with those factors that are there, and then it goes into proliferation and tractional detachments as it progresses. Now, the emerging evidence is even in DR, the cells are aging, but they are aging at a faster rate. So when they are trying to save themselves, they are going to produce the VEGF. So it is initially a chronic inflammation within the cell at the cellular level. Then it is going to produce factors which will try and get it vascularization because hypoxia is the predominant change that is happening in the retina. Now every single component of the retina, starting from retinal glial cells, the neuronal cells, the Muller cells, the RPE, actually contributes in producing these small factors like MCP, IL-6, VEGF, and ICAM. Now, am I just talking like that, or is there real evidence in patients? So this is an aqueous humor analysis. You can see that all those factors are present, and at different times, when the patient have different stages of disease or DME, you do have these factors which are kind of varying. Now, DR has the longest surviving animal model. This is from an SD rat. You can see that if you put streptozotocin in its peritoneum, it is going to produce DR. And we were investigating one of the targets, which was ICAM1. So the ICAM1 antagonist that we used was LFA, and it did produce suppression, which was as good as the VEGF. So the safety part is what we are kind of looking into, and the dose escalation part has to be looked into. And you can see that the model absolutely mimics how it is seen in the human patients when it comes to DR. Now, along with ICAM, since we know that the inflammatory factors are going up, now there is a cyclic GMP-AMP synthase which is kind of gets increased, and this will stimulate the interferon genomics. So how does the inflammation start within the cell? Is by the upregulation of the IF and interferon genes. So is there a way that if we kind of alter this, can the senescence be reduced? So that was the paper, and this paper got published, and we showed that the upregulation of the sequestering pathway is the one which produces early senescence. So considering this, altering or conditionally knocking out the sequestering pathway can also be one of the treatment modalities that we can probably see in the future, which can probably alter the way we treat diabetes at different stages of the disease and not just rely on VEGF or giving intravitreal steroids. Thank you very much.
Thank you, Thirumalesh. Swami can get ready here, and like to ask Dr. Dhanashree ma'am to give your comments on this, and Professor Sundareshan also after her. So the question I want to put it to this clinician scientist here is, so say 5 years from today, we're sitting in this kind of a panel. Do you see a more organized form of anti-VEGF? The word VEGF is because first targets were only VEGF, so that's why I use VEGF. So it's more like now we'll have to look at the different forms like LFA1 the antagonist or the ones which can block it are not VEGF blocking ones. So do you see that we will have to really look at the different forms of these customized therapies?
Yes, sir. So what we are trying to look at...
just be very brief so that...
We are just looking at alternatives apart from VEGF. So the ICAM that I mentioned is chronologically that is the first one to start. That is the one which switches on the angiogenic cycle.
Ma'am?
Very good work and wonderful talk. So there is always a focus more towards like looking at inflammatory, basis for all the diseases that we know. So even all these vascular diseases that we have been treating with anti-VEGF, there is some amount of inflammatory, modulation going on. So it is definitely essential that we look at all these molecules and look at the newer ways to and therapeutic targets that we have to identify.
So I think not only this disease, I think I was looking at the previous session by Professor Honnavar and Fairoz here, that every new disease has to be relooked at it. And you also worked on retinoblastoma, and I was just looking at that paper, the Cell paper on retinoblastoma with a new way of how you look at therapeutics. Everything has to be looked at in a different, different light. The time has come to move forward, and that's why when you say anti-VEGF, that means you're working only on VEGF and nothing else. So that is the mind block we have, and everything revolves around it. Different form of isoform, different part of biosimilars. So I think one thing is that we should come out of those name, and then you suddenly start looking at it in a different way.
Look at the whole holistic picture of the